Yeah. All right. Thank you all for joining us today. The ACMT Roundtable on MedTox practice and COVID. We have some panelists from across the U.S. Evan Schwartz, Brian Judge, Joanne Lace. Unfortunately, Tony Faison was not able to join us today. Tim Wiegand, Director of Tox at the URMC, University of Rochester Medical Center. We'll have a very busy consult service, and also Medical Director of Huthadol, an outpatient chemical dependency treatment program. Brian Judge is at Michigan State University, MedTox, EM trained. Joanne Lace is at Hennepin County Medical Center, addiction medicine, MedTox, internal medicine background. And Evan Schwartz is the Fellowship Director and Section Chief of MedTox Division of Emergency Medicine, or MedTox Division of Emergency Medicine, Washington University, St. Louis. He's MedTox addiction and EM. And so we have a good geographic background, no disclosures to make related to this. And hopefully we'll get to cover some good content, looking for a lot of audience participation. The goals and objectives today are to discuss the impact of the COVID-19 pandemic on toxicology practice and broader healthcare systems in different regions of the United States, to describe the use of telehealth in your practice. How's it done? Are you doing it pre-COVID currently? And then what do you anticipate afterwards? We're not going to get into the nuts and bolts of telemedicine. We have a previous lecture that's embedded into the e-learning site on ACMT's library for if you're interested in more specific information about telemedicine. And then we'll talk about opportunities for MedTox during and post-COVID, as well as barriers and implications and changes to your toxicology work, our toxicology work, or even broader professional work related to COVID, income, admin, research, support, as an example. I wanted to start the presentation going back to the annual scientific meeting, and you'll see this photo I took. This was the first day of the opioid symposium, and while we talk about the implications of COVID-19 on medical toxicology practice, we also have to consider the implications on the broader professional society as well as on our departments in the healthcare system, on reimbursement related to our encounters. And I thought this slide was very pertinent. Is you've got our President, Michelle Ruha, and Executive Director, Paul Wax, watching one of the presentations, which was done virtually. I have to really give a lot of credit to our admin support for facilitating a completely virtual conference. And at this point, this is the first day of the opioid symposium, and in second week of March. And we'd already started to get some of the ramifications from COVID-19. And when COVID-19 was first discovered in 2019, so before the turn of the year, but it really wasn't until March when I think, at least in the Northeast and as a professional society and as individual medical toxicologists, that we really realized there were going to be some broader implications and dramatic changes to way of life. I know within the first week to 10 days before the conference, we started getting some travel restrictions. I think the first was from one of the institutions in New York that was restricting travel within the city, and for good, it was a good measure taken early to limit contact at meeting sites, but it really changed the conference, and this is day one of the opioid symposium. This is at the end of day one. I know the first day it was the planners had gone to lunch, one of the speakers, the only ones that had been on site, and we had been eating at one of the local restaurants and realized that basketball events have been canceled. The NBA, Broadway was canceled, put on hold. And this is in the context of the New Rochelle outbreak. And we realized that things were evolving very quickly, and that, it was in the best interest of, everyone's health and well-being to turn it completely into a virtual conference. And so those of us that had flown into New York City made arrangements to head home. And, there's really, I want to give a lot of credit to Michelle and to Paul for all of their, wisdom and guidance in trying to direct there's information changing on a daily basis related to the conference planning. And, the reason I bring this up is, a lot of our contact and, our practice and mentorship comes from these annual events, which for the near future are really going to be changed and, really done virtually. And we've done a really good job with that, but that's certainly something to take into consideration, as well as will my CME money be there this coming year to attend such events. This is a photo I took as I was leaving Manhattan the next day from in an Uber on a ride to the airport to get home so I could do the virtual conference from my office at the U of R. And I thought kind of pertinent or poignant as it's captured through one of the bridges, the city silhouette. So a little bit about COVID-19 and my practice in Rochester. At the U of R, we started to get direction in terms of what's going to be the practice and protocol if we have a surge, what type of models of staffing will there be. And my practice is full-time talks. I split it with a colleague at the U of R. We cover 1 week on, 1 week off. And I have a team, clinical pharmacists. At the time, coming back from the conference, most of the rotators had been pulled from the all off-service rotations, and I was left with one emergency medicine resident finishing the rotation, who was given a little bit of an extension. All of the other EM rotators from from all of the non-critical rotations have been pulled, as well as med peds, IM, pharmacy students. And we had 2 emergency medicine residents from another EM program that we support in our Ogden residency in Elmira, New York, that were with us. And so rounds were interesting. We actually saw a drop in cases initially, as I think people were stunned in overdoses and intoxication and just general consults. There was some of the patients that had been hospitalized for prolonged periods of time were still on the list, the patients we take care of for opioid use disorder with endocarditis. But in the outpatient world, where I do my medical direction for addiction treatment, things were coming very quickly as we started to try and understand what the implications would be for the outpatient treatment world. We had high-risk patients that were identified that, within a short period of time, we had called to say, we're going to not bring you to the site for groups, for counseling, but keep you at home. And this is related mostly to outpatient substance use disorder treatments. Within 1 day, though, of this notice, we went completely to, and fortunately, due to regulations and emergency orders, we're able to convert from in-person treatment to all outpatient with state and federal guidance. And I'm not going to get into that in too much detail, other than my practice changed dramatically for the outpatient setting as well. And for a couple of days there, it was not clear where funding would be for the entire program. If the billing models changed, it had dramatic implications in terms of would the program even be able to sustain itself beyond the first and second month. And so there's a lot of panic, and emergency regulation allowed for counselors to visit with phone and with telemed, as well as the clinicians. And so it was basically turned into a complete telehealth addiction treatment program in New York State. And we were getting information from Washington that there were particular vulnerabilities within the system, and I included this for MedTalks in particular, as many more are adding addiction treatments, in particular related to buprenorphine and opioid withdrawal management. There are some high-risk populations identified, and we were looking for ways to potentially, the surge hadn't come, but we were looking for ways, well, what if the area opiate treatment programs really reduce on-site activities if more need support through the ED or coming to the ED, or there's limitations in access to inpatient programs and outpatient detox settings. Are we able to help support the ED if we get this surge? And so we were starting to make some arrangements to utilize telehealth and ambulatory detox as if the patients were coming in using some protocols to support rapid identification in the ED and then linked to telehealth follow-up in the tox clinic from the hospital or linked to outpatient treatment programs. Some of the early information about methadone maintenance in Washington State in some of the programs showed high rates of homelessness, high rates of comorbidities, a lot of movement throughout the community, congestion at single sites because of med dispense, collection. And so in my world, I was thinking, I've got a lot of vulnerabilities. And first, I'm on site in a lot of these, in the ED and at the hospital as well as the outpatient program. How am I going to, protect myself, make sure that I'm not exposed? What are the implications at the end of the day for coming home to my family? And then how do we best support the patients? So there's a lot of phone calls and trying to understand, good models. Guidance was coming on a daily basis for the hospital systems, as you all participated in, I'm sure, and will be interesting to hear. There was the COVID-19 task force set up in the hospital, and then in the EM staffing models, there was deputization or credentialing that was allowed for many people that hadn't practiced in the inpatient ICU or ED setting in some areas of the country, New York in particular. If the surge had come, I was given credentialing for inpatient medicine practice if we needed it, although I anticipated doing mostly tox and offloading the ED, but we're all preparing for this big surge. And this is a time where there's a lot of PPE shortages and testing was limited, and there was a lot of questions and answers and guidance. ACMT started to put out the first of what's turned into a remarkable webinar series, leveraging the expertise and staff that have a lot of skill in getting the webinars and educational content available online, allowing access to the e-libraries, and the other tox societies joined as well. And I thought some of the collaborative efforts have been really outstanding, and we've really come together nicely as a community in particular related to this. There's some outstanding content. Other professional societies started to put out guidance related to education and practice, in particular, how it impacted their patient populations. And, one of the presentations I had given, I think the telehealth one in the middle of April, was able to reflect a little bit on some of the opportunities and challenges. By this time, it had been clear that telemedicine was going to be needed, and that was going to stay in some way, at least in my perspective. We've been using telemedicine prior to COVID for tox support in New York. There's parity, but in reimbursement, but really not as much as the bedside consults. The first clinic that we turned into completely telemed offered support for the tox clinic was the third week in March. Within a 48-hour period, my administrative assistants and one of the other toxicologists, addiction providers, and I were able to connect via Zoom or Doxy.me to, I think, 16 patients with opioid use disorder from the hospital to their home and bill successfully for them. And then due to the regulations, there was some opportunities for expanded telehealth support that I was getting from some of the regional hospitals, and we're still trying to figure out how to bill for those encounters. But due to some of the regulations, it seemed that we would be able to. It's just that submitting the bill through the correct electronic mechanism we're working on. But we had to look at support for some of our patients in the hospital in a very different way. In particular, about half of our consults on the U of R tox service really are related to opioid use disorder, and a lot of times family support, peer support, friends coming in with the visitation policies changing, that was no longer an option, and so connecting them via iPads, using FaceTime to local peers or other family members, even the treatment programs. A lot more smoking cessation added on to consults. That was interesting. There's some opportunities for poison control. You've seen presentations from Diane Colello and some of the others that had leveraged the poison control center in unique ways to support COVID-19. And there's a lot of vulnerabilities and challenges, though. We saw more exposures to young kids after that brief lull, and exposures, our service really picked up. And while there was numbers in the ED and the overall hospital were low, our consults were surging most days and most weeks. There was a lot of accidental exposures, more stress, more alcohol withdrawal, more dramatic and severe alcohol withdrawal, more overdoses, the opioid overdoses, which had seemed to plateau in our area, started to increase dramatically. And we had to really start also looking for novel ways of linking patients to programs without that walk-in ability the next day, in particular for our opioid use disorder or addiction patients. So I'm going to stop right now with kind of the background and just ask our panelists some general questions, and we'll get the audience comment, chat, or raise your hand after we've gone through the panelists. But we'll start with Dr. Schwartz, Evan, and the question really is to describe the evolution of the COVID-19 pandemic related to your healthcare system and toxicology practice. How you've seen it evolve from your perspective.
Sure. Thanks, Tim. So kind of like you already said, and I'm sure what happened to other people as we got into this COVID time, our volume suddenly dropped. We also had, lost a lot of our rotators, and a bunch of our faculty were furloughed. They're all back. But the biggest problem was volume dropped. We have been doing addiction medicine here for some time, but our PA was put on furlough, and we still don't have her back. And then on top of all this, we're in the middle of a chair search, which the university hopes to still have completed in the next couple months. And the reason I bring that up is whenever that new chair gets here, they're going to look at our numbers. And as of right now, we're planning to have 6 toxicology attendings next year. So I have to have kind of numbers to support them and support their hours. Their hours did go up a little bit ever since COVID, but when that new chair gets here, he or she is going to want to see evidence of what we're doing. So with all that said, the things that really helped us were both the telehealth as well as having addiction as part of our service. Kind of similar to what you said, about half of what we see is probably addiction related, and has really helped keep our numbers up and keep everybody busy, and help have, continue to provide a service to the hospital and patients, but also be an area of revenue that we're bringing in that we can show to our future chair. In addition, it's also helped us get several grants, which also prevented even further hours increase for many of our faculty. The other part was telehealth was really helped for a couple things. First, our outpatient clinic was very slow. The clinic just wasn't very efficient to begin with, and a lot of our patients were late or had transportation issues or things like that. So actually being able to do virtual visits either over the phone or through Zoom on a computer actually makes it a lot more efficient. We can actually see more patients in a shorter period of time and get through them. Patients also seem to like that better. The stable patients that were there and just were there for very short periods of time, or had kind of minimal exposure to some solvent or chemical and didn't need any lab testing or anything else like that, they like this a lot better than having to drive in, wait in the waiting room, and kind of take a whole morning just to see us for 30 or 45 minutes. In addition, in our emergency department, we can also see patients over an iPad, which does help, meaning the faculty don't necessarily have to come into the emergency department to see these patients. Or if they're working at the children's hospital and there's a patient in the adult hospital, they can just go ahead and set up a Zoom meeting and see them and do everything they need to do, even if the resident or fellow is seeing the patient in person. And finally, this has really helped us expand our telehealth to other hospitals. We've been in the process of trying to do that for a couple of years. When Jason Devgun came here about a year ago as one of our faculty, that was going to kind of be his big job of trying to figure out how to do this, and things were moving along at an incredibly slow pace. And then with COVID, that really has taken all those restrictions off. So we're hoping to be able to provide teleservices to at least one other hospital in the area very soon, and then that'll hopefully expand to other areas. So giving, more services to some of these hospitals and their patients, but also a way to kind of increase our yield of what we're doing, which I think will be important for our long-term sustainability.
That's great. I just have one question. What was the use of telemedicine before? Was there parity, and when the state of emergency ends, will that have implications on your ability to provide telemedicine, or not as long as you have the credentialing and system set up, will be able to get the same reimbursement, or any comments on that?
Yeah, that's a great question. I do worry about in our clinic whether it'll let us do that. As far as the inpatient consultations at the other hospitals, I think that should be okay because the credentialing and technology should still be there.
Yeah, that's great. We have some resources online for people that are interested in credentialing, paperwork, examples. If after the webinar people are interested, can email. Brian, Dr. Judd, do you want to comment on the implications, general implications related to COVID-19?
Well, our hospital underwent a lot of the changes that you had outlined, Tim, in terms of dropping rotators from our service and pulling them back so they could cover their home services. We did not see a drop in our bedside consults, interestingly. In fact, it was quite interesting. While most of the hospitals saw a 40–50% decrease in patient-related services, our medical toxicology service was business as usual. And we did not end up doing telemedicine. We still did bedside consults with appropriate PPE. And so it's just interesting. And some of the overdoses that we saw tended to be more severe than we would typically see on our consult on a weekly basis. So I continued to be mobile. I worked in Grand Rapids. I also work in the Upper Peninsula, so I traveled quite a bit. There would be times when there'd only be 2 people on the jet flying up to the UP. And so it's, we didn't really see the surge of cases like other parts of the country did. We did a lot of preparation for it, and it just never really came. And things are kind of eventually getting back to normal here from a patient volume standpoint for our hospital. But really, all in all, there's not a lot of significant changes for our bedside consult service. Do you want me to talk about other elements of my medical toxicology practice, or is that later on in the talk?
You can go ahead and mention some here. That's fine. I think we have some opportunities and challenges, later on. And
sure. So like other medical toxicologists, I do medical legal consulting. I did not see any drop in that business line either. I probably had 1 to 2 cases coming in a week. That's about typical for me. I had a little more time to focus on that aspect of my practice. Because I have an LLC as well, I was able to apply for a payroll protection program for my LLC and qualified for that. So I don't know. I know ACMT took advantage of that. My own private Democratic physician group took advantage of that. And I'm just curious if some other medical toxicologists who do consulting work on the side were also able to take advantage of that.
Yeah, that's a great point. I had formed an LLC this past 2 years now and was able to take advantage of that as well. I would not have realized it had our accountant not mentioned it. But yes, it's interesting. One other comment, as long as you brought up the medical legal, I had some deposition canceled or moved because of travel restriction, and trial delay because of travel restriction. So there certainly were some other impacts related to the travel restrictions as well, specifically. But yeah, that was a good comment, and one of the benefits to having an LLC. We'll move on to Joy.
Yeah, go ahead. Just I did. Had a couple trials canceled, but I did end up doing a deposition by Zoom, which is nothing new, but it's just not typical. so I was at least able to do that. So thanks, Tim.
And Dr. Lace, Joanne, would you like to give us some of your impressions?
Mainly what I do is methadone opioid treatment program. I don't do very much office-based outpatient buprenorphine prescription, but I do a lot of inpatient addiction medicine and some toxicology consults. And because we don't have a formal inpatient bedside toxicology service, it was decided to decrease exposure risk that we would cancel the inpatient bedside toxicology consults. My addiction medicine consult service for inpatient volumes went down at first, and then they've rebounded some, but they're not quite at the pre-COVID levels that they were. What we did start doing was we ended up calling the hospital rooms for patients in order to see them, especially if they were diagnosed with COVID. We have addiction medicine counselors that have been pretty much working at least in their office and calling patient rooms or working remotely. The methadone program went through the most dramatic changes. Everybody starts out at the methadone clinic coming 6 times a week, and you can't change that attendance rate until 3 months in to your admission to the treatment program. However, we started switching people from 6 times a week down to 3 times a week after getting guidance from the federal government that loosened those regulations. And people who were only coming 1 time a week to the clinic got moved to 2 times a week. So that was pretty significant. We're not doing urine drug testing on them, so we're operating blindly with concern for overdose risk for a lot of these patients. And we also weren't taking admissions into the methadone program for a long time. And so my understanding is that street prices of drugs went up. People with unemployment had a difficult time procuring drugs. So there was a lot of concern about people selling methadone or selling their other medications for money or for other substances. And we have adapted back to, we're seeing about half of our patients bedside, half via the phone for the inpatient service. I know that the office-based clinic is still seeing people via telehealth or video, which has been a little bit of a limitation because not all of our patients have video capability and not all of them have working phones. We continue to do injections in the clinic of Sublocade or injectable naltrexone. And methadone clinic has started to be able to accommodate doing urine drug testing again, as well as actually having people inside of the clinic instead of lining up on the outside to get dosed.
Yeah, you bring up some great points. And it was interesting. Some of the consult services at the U of R changed completely to either phone or telemedicine, audio videos supporting the hospital. The talk service, our talk service wasn't one of those. We did mostly bedside with Dr. Naka and I going in, but really a small team. After the first couple of weeks, it was just ourselves separate going in. Although I did do in some cases of COVID-19 phone consultations, doing the full history and physical, waiting to see if there's actual parity for the phone calls without the video when there wasn't the availability, but it seems like the parity for audio and video when done will occur as it has even pre-COVID too. We continued in the outpatient setting in the outpatient treatment program to do the injectables and started to get a lot more referrals related to the subcutaneous buprenorphine as well as extended release naltrexone, and I think had set up a very good system. A lot of the staff were furloughed, which is unfortunate, but actually turned out fortunate for them in terms of the income and unemployment as well as some supplemental benefits. So they weren't, there wasn't a lot of financial fallout, at least yet. It remains to be seen, moving forward. But, the outpatient setting, because we continue to have access and also continued separate crisis visits on site with appropriate PPE and things. So there were some gaps in the system that really, if you were available and accessible, I think, as either a program or a provider, it was really, useful and visible. So that was great. The next slide mentioned, we've already talked a little bit about telehealth, and we'll go back. I've described my telehealth practice a little bit, but I can go over. We started doing telemedicine really in 2016 when the parity laws for New York State were changed, when it was mandated that where a inpatient encounter could occur, if that was not feasible, if the provider was appropriately credentialed to provide the service at if you're providing it from a hospital to another hospital system, you had to be credentialed at both sites. So it couldn't be just simply randomly to, whichever hospital or whichever provider or to a patient's home. That changed during the COVID pandemic. Most of the telemedicine that we did, we were already set up with, although in the toxicology clinic, as Evan had mentioned, I anticipate we won't return to a model of all clinic is going to be in person. We will still be able to utilize telemedicine support. And I think most of the patients, I had for real stable patients on buprenorphine every other month in person. I changed to monthly just to connect for isolation, support, stress, and many of them weren't able to reach their primary care physicians or had emergencies and were able to provide a little bit of support and guidance. And some of them really appreciated just the face-to-face contact. In the hospital, the university clinic for toxicology, we didn't do phone visits only because the parity for the clinic, it didn't seem like it would, we weren't anticipating that to occur after a few trials. And so it was all 95% real-time audio video. I got to really see some unique aspects of patients' life. Some of them were able to show me their hobbies, the gardens. They really appreciated it, and then also appreciated not coming in. Some of them really were frustrated and preferred to come in particular in our area, as we had some of the protests and then riots related to, racial injustice. They had some African-American patients that I worked with for quite some time that really wanted to come in and see in person and talk, and we're able to arrange that separately. But you could see that, the mixture of telemedicine and in-person visits really would be an ideal kind of venue and save us some rent as well, and save us some support costs for we rent the toxicology clinic from the occupational medicine site. So does anyone have any other comments or questions or pearls regarding telemedicine? We'll start with Evan, and we can take some questions from the audience. We've got a couple of other specific areas to discuss, but we can take a few questions after we go through the panel. Evan.
Yeah, sure. So it's been interesting. So we still do some in-person visits, but we also do quite a bit of telehealth through the clinic, as I mentioned. Particularly with the phone visits, I'm worried what happens when those go away, especially since it tends to be probably our patients with the least economic status or resources, I guess, that really just want to do the phone visits, and it's harder for them to get here. From just the general toxicology, it's helped because people no longer have to travel 2 or 3 hours sometimes to see us in clinic. What's interesting is one thing I didn't anticipate is after we went to kind of a lot of virtual format is the hospital actually started getting pretty upset after first encouraging it. They realized they lost all the facility fees. So almost a week after saying we should do all this virtual stuff, they started complaining about us doing virtual stuff. So I don't know what the hospital is going to do long term because there's obviously the safety and the patient satisfaction, but when we do everything virtually, they lose their facility fees. So it'll be interesting to watch that.
That's interesting. I hadn't really considered the difference in the facility fee, or if there's, if it would vary depending on provided to a standing clinic that's going to have staff there, whether you support like it's a multi-specialty clinic or it's back to the hospital. That's very interesting. Brian, do you have any other comments related to telemedicine?
I don't have any comments on telemedicine, but financial impacts, if you want me to talk about that, or is that a slide coming up?
No, go ahead. You can comment on financial.
I think I'm very fortunate. I'm contracted with my hospital with 2 other toxicologists to provide bedside consultation and phone consultations 24/7, 365. There were pretty significant cuts, and I'm sure this is commonplace amongst other institutions. I know that our medical group, which we're not a part of, they all had to sign an agreement to take a 25% reduction in pay until June of 2021. The other institution I work at, they had to take a 15% reduction in pay through June 2021. I know many EM physician providers in my group had to take significant pay cuts, reducing hours up to 50%. So, I think the financial impact, while not as great for my service, I think probably certainly has been felt across the nation. I guess I'd like to hear from some of the audience members what their experience has been or what they did to supplement income or protect their income during the past few months.
Yeah, you bring up some good points, and I can finish with that, or I'll let Dr. Lace comment if there's any other additional comments on telemedicine. It's a great segue. We have impacted the U of R. First, there was salary cuts above a certain level, up to 10% of the salary, but that was requested to be voluntary. Staff were being furloughed by administrative assistants for the toxicology clinic, as well as support for all of our toxicology resources, the rooms, some of the scheduling. Basically, our toxicology administrative assistant was furloughed for 2 of the 5 days, so she would be able to still meet certain criteria for some of the support. But that changed patient flow for the clinic. We have about 60 patients a month, between 60 and probably 80, maybe not quite that much that we see in the clinic. There's a lot of phone calls related to that. It turned out after then the voluntary pay reduction that were going to be mandatory for July, they pulled that back and cut benefits. So retirement plans were cut pretty dramatically above a certain matched income, and I think there's still potentially some to come. I don't know. It's people were quite upset, but they tried to look around and justify this based on similar institutions. But there's a lot of frustration over the EM providers, ICU medicine providers still providing services and getting cuts despite being active and available, and a lot of frustration around this. Joanne, do you have any other comments regarding tele? And then we can move to discussion about finances or other implications related to your practice.
With the telehealth, I think it's nice because I do feel like I'm actually able to see more people. However, the patients who already were a little bit confused with all the different people coming in and out of their rooms, it's hard for them to continue to keep it straight, and it takes away a little bit of the relationship with the patient for if difficult situations are coming up, like disagreements on treatment planning or limitations within the hospital with visitors and such. For the clinic, I think that sometimes the limitation with not having the video was really hard on the clinic doctors, because sometimes you don't know whether patients are giving you inaccurate information about how they're doing, and just having a quick glance at what they look like physically would tell you a lot, whether they're being compliant with their treatment programming or whether they're struggling more. But I think those have increasingly been ironed out.
Yeah, thank you. It's interesting doing about a third of the patients that I see, maybe a quarter in the outpatient addiction treatment clinic don't have the capability for video, either computer or smartphone, and so the phone-only encounters occur. And I noticed that there's a much higher rates of either seeing them in the hospital, noticing that they had an overdose or some complication. We've not been able to leverage the video, observed doses, things like that. I think the phone only has also allowed us to connect to patients with which we would have had no other way of connecting. As of July 6th, from what I understand, things change federally in that there will no longer be parity for the phone calls, and that there's a possibility that will be changed, but that's my understanding. And so we're trying to determine the implications for patients we're not able to reach just via, that we're only phone only. Do they have to come in? Will we mandate audio, video, some other way? How do we do this? Still working that out. We can talk about education a little bit. Before going to education, though, as Brian brought up, I think let's talk a little bit about the financial impact. As you know, the repercussions are huge. Just having my experience after fellowship and a year at UCSF was negotiating a breakdown of tox and medicine. FTE is a split associate poison center director, and to start a new consult service. And this is in 2007 when I had traveled to Maine Medical Center, and the start of the recession really impacted hospital systems as well as the nation. And I was a little naive about contracts, and at the time they hadn't really had a bedside consult service, and so it was left ambiguous in terms of what that would be. But we're going to put this together: withdrawal, a clinical pharmacology, pharmacy service, and it was left that when you get to the site, we'll put this together. It'll be a substantial portion of your contract, but a significant amount of time had lapsed since my site visit, and agreeing verbally to what the practice would be. And the reality is, when I arrived, they didn't have the funds to support the tox service, and I didn't have the numbers to say, here's how much money I would be bringing in. So I was left doing a lot of hospitalist work as well as the poison center work, and I was very frustrated. Learned a lot about contracts and specifying exactly what you have done. And one of the things that's really driven home is you really need to show your value and to understand where your value is. And now more than ever, as people are moving forward and looking to start new services or continue doing toxicology or expand their service, you really have to be able to justify, why is medical toxicology valuable? Because there's shortfalls, dramatic shortfalls. U of R is close to $500 million shortfall in income, and they're cutting salaries and cutting or increasing time, and you have to show that you're valuable to continue that service. Then we need to be ready as a professional group, as well to answer where is the value of toxicology. So let's take some comments or questions from the audience. Does anybody have any questions or want to share a specific impact on how COVID has impacted your practice? Or your experience? Rama, unmute you. Go ahead.
Thank you so much for this session. I have a question because I think an area where we really have some expertise is in patients that are sedated for prolonged period of time who have never had dependency or tolerance issues in the past, trying to wean them off to get them extubated. There seems to be a growing number, and I'm wondering if anybody could speak to how we could leverage that expertise amongst us all to be considered an essential service.
That's a great question. In fact, I don't know if anyone was on this past Third Friday Addiction Tox Case Conference, but one of our cases featured just that. And one of our ICU fellows had approached our tox service saying, these COVID patients are just like the severely dependent sedative opioid use disorder patients you help with sedation weans on. Do you think that that the management might be the same with buprenorphine or phenobarbital or other protocols that you utilize? and actually, we've got one of our ICU attendings in this. I encourage people to listen to this last Friday joint ACMT conference. But it's been an area where we've seen a number of consults. Prior to COVID, it was in complex sedation wings in the ICU for opioid use disorder or sedative use disorder. And now, during COVID, we've seen a couple of requests for help with really severe iatrogenic dependence. The lack of sedation holiday, the need to paralyze, give higher doses of opioids and analgesics because of the decreased patient contact, because of the need to use PPE and risk for exposure, all led to much greater rates of iatrogenic dependence. And so, yes, on our service, and we've got a couple right now, but I'm wondering if anyone else does as well. That's a great question. Thank you. I'll unmute you again if you have any other follow-up comments, Rama. You're unmuted if you had any other comments. Otherwise, if there's anyone else that wants to respond, are you seeing this as a part of your practice, or is this an opportunity?
Yeah, I can just say that we definitely have been helping groups that we typically wouldn't normally help. So for example, because of the overflow from our ICUs into the CT surgery ICUs and the burn surgery ICUs, the cross specialization that are accessing us is broader. And I'm not sure if other groups have had that same experience, but it might be something worth bringing to the attention of those groups if they could use you.
Yeah, thank you. Does any of the panelists want to comment on? Just unmute yourself. And Evan, is this an area that you've been involved in?
Oh, we haven't really been involved in it, but it definitely sounds like a great way that we can show our value in that getting people extubated sooner and out of the ICU, especially when they're all so busy. Is definitely something of value to the institution, I'm sure.
I don't know if anyone from Banner Health has been on, but I've spoken with Dr. Ruha about the increasing cases in Phoenix, and as an admitting service, she had mentioned that they started to see reduced transfers. So there's not too many admitting services in the country. I think Tony Pison, they have the Pittsburgh group has a hybrid service, and that's like probably most of them. The rest of us are really consult-based, and so this certainly, as you increase the numbers in your hospital of COVID patients, you may have a unique role to help with sedation weans and pharmacologic management. Let's see, there's some, let's see, do we have any chat questions? Let's see. Oops. Does anybody, any other audience have any comments related to this? Brian or Joanne, do you want to comment on the ICU care of COVID patients? Is that something you're doing in your practice?
No, I've not done that.
Okay.
I have not done that specifically in recent times. However, occasionally for addiction, we'll get consulted on possible withdrawal from the long-term use of sedative or opioid infusions, and it's always really difficult, I think, to plan a taper plan because it just seems like the receptors get very saturated, and so the historical thinking of doing like a 20% taper per day, you can actually go a little bit faster than that at first and then slow down a little bit later.
Right. This is a regular topic on our third Friday case conference. Henry Swoboda was on this past Friday, and we discussed some of these complex cases with some experts from ASAM, and it is a real opportunity in some unique pharmacology, doing what's called microinduction, starting buprenorphine while people are still kept on opioid agonists. And trauma patients that have opioid use disorder, we start while they continue the full agonist. So not going to get into the weeds on doing that, but I think as you really look for showing value, having other services say, we really rely on them to help us simplify our care, get them out of the ICU, keep them from coming to the ICU, bridge or get them out of the hospital, or make the stay overall better and safer, I think is a huge positive. There's a little bit a mention on, some discussion of financial implications related to COVID and salary or benefit cuts, and it's really important. I want to reiterate to know your value in terms of what you're bringing in, what you're charging, what you're bringing in, and then in addition to not just what your reimbursement rates are, there's another symbol value that's a relative value unit. So tracking your consults, the number, the types, the CPT codes is really important because it may not be what you're bringing in terms of revenue, but the institution may understand relative value units and how busy you are, and that's another way of demonstrating that you're active, you stayed active, you're doing different things, and got to get really good at explaining to your chairs. So let's talk a little bit about education, how your toxicology education, your program was impacted by COVID-19. We've gotten a little bit into this. Our rotators were mostly pulled very quickly. We kept a couple, have since resumed the toxicology rotation. Dr. Nick Naka, and one of our clinical toxicologists, were able to offer a unique remote asynchronous learning combined with a daily check-in remote or virtual series for 1 week, and a curriculum of 5 days of several different things, of rounding via Zoom, and then some reading and assignments, and then a topic at 3 o'clock in the afternoon. They did this in every other week for a group of medical students that had interruptions to their normal rotations. And it was very well received. And I know a number of others were involved in virtual learning opportunities. ACMT in and of itself opened their library as resource to a lot of to broad groups, the public, and I know quite a few different groups at our institution commented on, as I sent out the link and information, commented on some content that they were able to use, in particular sustained ED modules. But what about the toxicology education? Evan, at your institution, what adaptions did you have, and where do you see this going forward?
Yeah, we've still been able to deliver a bunch in person, and all our rotators are back. With that said, we kind of had more of a citywide conference, and so that's all virtual. And where it's been different is our offices aren't located in the poison center, so it's at a different site. So our rotators can no longer go over there. Our fellows can, so they'll bring back interesting cases. But that's been one thing that's been really different for us.
Brian, do you have anything else to add or comment?
I don't, Tim. Just a few of our rotators were pulled. We still had a complement of residents that rotated with us. Our medical students were pulled, though, completely, and they're just starting back up with this new academic year. So we did lose that element of our educational arm, but I expect that will go back to normal with the new academic year that's just in front of us by a couple of days.
Joanne, any other comments regarding your education?
No, I feel like it's really been hard to do the online education delivery. And what I mainly had been working on teaching was the logistics of altering protocols at detox or at methadone programs.
Yeah, there was a lot of, at first, requests for online learning as the in-person events were canceled and people needed some content filled, but so a lot of Zoom meetings that I participated in did much more professionally, state and at the national level, a lot of focused topics, ambulatory detox, telehealth, but also noticed the fatigue. There's a lot of different groups are now offering online resources, and there's a lot of competing content. Our core curriculum for the emergency medicine residency was turned all virtual, and initially there's some logistics with logging in, logging out with Zoom. I think that's mostly been resolved. So I think it seems like people have gotten really better with IT to support virtual learning, and to compete moving forward. You have to be pretty good in presenting and not just a simple PowerPoint slide, but really get good at how do you do virtual learning, especially if this continues for any duration into the future. We've got, I think, really the last slide is to discuss opportunities and challenges. We've covered some of this already in telemedicine, talked a little bit about salary, time, benefit changes, research. And is there any other comments or pearls that panelists would share? And then we can end if there's any other questions or comments that the audience has. Maybe Dr. Wax, you want to comment at the end as well. Let's start with Evan. Any additional?
I'm sorry, go
ahead. No, go ahead, Brian.
Yeah, one thing we haven't talked about is I don't know of any of my colleagues that have come down or contracted COVID, but, we're small departments or divisions, and what do you do if somebody's quarantined or out ill for a couple of weeks in terms of covering the service? I don't know. Maybe some of our audience members can comment about that too. We've been very fortunate. Everybody stayed healthy. In fact, I think everybody from our 100 strong physician group has stayed healthy as well.
Yeah, that's a good comment. I thought about that if I had to cover clinic or something, and anticipated as long as I wasn't, too sick, I would be doing telemedicine. But I thought about also going home each night. If I, the PPE was on site and went rounding in the hospital, had a kind of a ritual of stripping down in the garage and wiping down, a lot of hand sanitizer, and then showering clothes in a bag. But yeah, that's a great comment. Does any other Evan or Joanne thoughts on that?
It's something we luckily didn't have to run into. My thought being, if you were more furloughed because you were, or not furloughed as much, but not allowed on campus because you were exposed, or had a little congestion, were positive but weren't really, weren't sick in that you were really bedbound, is maybe there's a role for telehealth in that to try to help with coverage. But yeah, otherwise that could be a huge disaster. You have 5 faculty and 3 of them are out because they're truly sick, and honestly, then they shouldn't be working.
In fact, now that I think about it, I was quarantined, and I was quarantined because I was in New York for the ACMT ASM. Not by my home institution, but a much smaller hospital. And so I was quarantined for 14 days because I had been to a high-risk area. And I'm sure other people face similar situation or challenge.
Coming back, I had not been advised to do that, but I was required to check with our occupational environmental health office, but was not, which was interesting thinking back. I don't see anybody's hands up. There's a lot more to discuss. There's certainly, I think this is an evolving area, and we really don't have all of the implications on the healthcare system. We're facing Medicaid cuts potentially, and institutions that are tied with academic centers in particular. If the enrollments with undergrad or graduate school is down as people take gap years and things like that, if your medical center is also involved in supporting the university, there will be further downstream implications, which we don't know yet. So really, again, you got to show your value as best you can. Dr. Wax, do you want to give any comments?
Well, I would like to just to thank Tim and the panelists for really a wonderful presentation today, and appreciate the interactions with the with the attendees. I think we should continue to do this on a fairly regular basis. Maybe every other month or at least once a quarter. Going forward, there are all these changes which are continuing to evolve, and part of the purpose of these sorts of sessions is is really to provide not only communication with the members, but also to have the members be able to share their experiences with others, because we all learn from one another. So I'd like to encourage you all to continue this sort of thing. Somewhat poetically, perhaps, today the Broadway Theaters just announced that they're going to stay closed through the end of 2020. And it was at ASM on that March 12th date that that the Broadway Theaters first went black at the beginning of the pandemic. So I think we're all in this for quite a while. It's going to have impacts on our practice, but also potentially prevent new opportunities. Even some of the standard COVID science and medicine is a little bit outside the neuro or toxicology lane. Our webinar series and some of our other activities has really given us a greater platform in many ways to interact with others beyond the membership as well, and I think some positive downstream impact and further potential. So again, I'd like to thank everyone for joining today. I'd like to thank Tim and Evan and Brian and Joanne, and everyone should have a good day.
Thank you, Paul. The telemedicine webinar is on the e-learning library. There are some resources in particular related to that. And again, for some of the content, as Rama brought up, there's a lot of discussion over the overlap in tox and addiction and specific examples that I encourage people to look at if you're interested in adding that to your practice. And then all of us are also accessible if there's questions. And in particular, I've had some billers and coders at the U of R who have volunteered a lot of time just simply answering questions to fellow toxicologists on their practice billing coding. So again, thank you for hosting this, Paul and Adrian, and helping set up. And thank you, Brian, Joanne, and Evan, for panelists. Have a great afternoon, everyone. And hopefully we'll get some comments and can further discuss in a couple of months, coming back to a panel discussion again.
Great. Thank you, Tim. Thanks, everybody.